Good evening, everybody, and welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Stanislav Bondarenko from Ukraine. Dr. Bondarenko is an associate professor at the Sytenko Institute of Spine and Joint Pathology in Sytenko, Ukraine. After his internship at the Kharkiv State Medical University in June 2002, Dr. Bondarenko pursued orthopedic residency at the Sytenko Institute of Spine and Joint Pathology in Ukraine. He's an active researcher with more than 34 PubMed index publications and has received research grant from the EFORT Foundation as well as the American Academy International Surgical Scholarship Grant. He's a national representative from Ukraine to the European Hip Society as well as the International Society for Orthopedic Surgery. So today it's my great honor to introduce you to Dr. Stanislav Bondarenko from Ukraine. Over to you, Stanislav.
Thank you very much, Dr. Kitesh, for your introduction. I'm great, and today I would like to share with my colleagues my experience connected with management of unreduced fracture dislocation of the hip with total hip arthroplasty. The number of patients with hip trauma is steadily growing every year. Preserving surgery remains a priority for their treatment, especially in young patients. However, the percentage of complications following surgical fixation of acetabular or proximal femur fractures remains high and amounts about 10 to 40%. In cases of unsatisfactory results of the treatment in this category of patients, they develop post-traumatic osteoarthritis, avascular necrosis of the femoral head, or unreduced fracture dislocation of the hip, with changes of the anatomy of both the acetabulum and proximal femur. In this case, total hip arthroplasty remains the only effective procedure to help this category of patients. Total hip arthroplasty at unreduced fracture dislocation of the hip is technically challenging due to the presence of deformities and bone defects after previous surgeries, osteoporotic and osteosclerotic bone, presence of pelvic discontinuity, the presence of scar tissue, presence of heterotopic ossification, significant degeneration, and retraction of peracetabular muscles. In addition, the presence of hardware, which should be removed, also complicate total hip arthroplasty. The problems and technical difficulties at total hip arthroplasty include the insertion of the cup on the levels of true acetabulum, reduction of the implant head, high risk of post-traumatic nerve pulses in dislocation exceeding 3 centimeters, increased risk of deep vein thrombosis, high risk of infection, increased risk of revision. According to data of actual peer-reviewed publications, outcome after total hip arthroplasty and sequelae trauma are worse than outcomes of total hip arthroplasty after osteoarthritis of the hip. The percentage of complications amount from 12 to 25, and most frequent of them are early aseptic loosening, instability, periprostatic joint infection, and periprostatic fractures. Post-traumatic defects of acetabulum walls at total hip arthroplasty complicate both preoperative planning and surgery. In systematic review of the literature published by Macridis, the results of total hip arthroplasty and the frequency of complications in more than 600 patients after acetabular fracture were analyzed. In the group of patients where total hip arthroplasty was performed in the earlier period after acetabular trauma, according to Kaplan-Meier survival rate for aseptic loosening, 10 years after surgery for the acetabular component of implant was 81%, whereas 76% in the group where total hip arthroplasty was performed in patients with old acetabular fracture. By performing total hip arthroplasty in patients with unreduced fracture dislocation of the hip, it's very important and challenging issue is to achieve primary stable fixation of the acetabular component. In this case, a significant role played by the acetabular cup coating, on which secondary biological fixation of cementless total hip arthroplasty depends. It is especially important for young and active patients. New highly porous tantalum and titanium acetabular components have been developed to enhance also integration and survivorship of acetabular implants. The advantages of these components are related to amelioration of primary stability, the improvement of physiological stress distribution, and enhancement of osseointegration in comparison with conventional press-fit porous-coated titanium acetabular cups. These implants should be considered for application during a complex primary total hip arthroplasty in patients with unreduced fracture dislocations of the hip. Specific technical issues include reconstruction of acetabular defects with use of oite or allografts, restoration of hip rotation center, use heads with large diameter or dual mobility system to reduce the risk of instability. Selective removal of hardware during total hip arthroplasty is also a very important issue. In cases when we have post-traumatic dislocation of proximal femur, we should consider about two-stage technique, which was developed in our clinic. It's connected with two-stage. First stage, like in this case, you can see the young patients after trauma with ankylosis and dislocation of proximal femur and ankylosis on the level of the ilium. In this case, we perform osteotomy at the level of ankylosis, and we use external fixation device, and we distract the femur to the level of the true acetabulum, and after that, we perform the second stage, primary total hip arthroplasty with the construction of the superior wall of acetabulum with the use of allograft. Also, this technique we could use in the cases of pelvic discontinuity. We use bilateral external fixation device, reduce dislocation. It gives us opportunity to achieve, in some cases, continuity of the pelvis. And on the second stage, we use primary total hip arthroplasty, and no need to use special cup cage technique or tri-flange individual components. Alternative option in this case, due to recent data, is to use cup cage technique with reconstruction with use of allografts. This technique also have good results in medium term of follow-up. To conclude, careful planning of the surgery, differential approach to choosing the design of the implant based on bone quality, biological restoration of acetabular and femoral defects, ilofemoral destruction to restore leg length equality without nerve palsy and avoidance interoperative technical difficulties, provides positive results of treatment in total hip arthroplasty at an unreduced fracture dislocation of the hip. And to use this opportunity, I would like to invite my colleagues to take part in the 4th European Hip Society Congress, which will be held next week in Lille, France. This is two-day event with participation of high-profile European and international experts, includes symposium and sessions on innovation approach in treating major hip pathologies, from reconstruction surgery to revision arthroplasty, discussion on complex cases associated with complication, total hip arthroplasty diagnosis, and management of preprosthetic joint infection. Also, the program includes the possibility of personal communication with high-level experts on a number of issues connected with hip joint pathology. We are looking forward to see you in Lille. Thank you very much for your attention.
Thank you, Stanislav, for that brilliant presentation, and congratulations for the brilliant work that you do at Ukraine.
Thank you. Thank you, Dr. Hitesh.
A couple of questions. What are the rate of complications that you see with this kind of fracture dislocation of the hip, especially with respect to sciatic nerve palsy?
Oh, thank you very much for this very actual and important question. In most cases, patients with sciatic nerve palsy as consequences of trauma of the hip have adverse outcomes after total hip arthroplasty, and this connected with innervation deficiency, which leads to complications connected with wound healing, instability of the implant, limping, spinal pelvic disbalance, and the necessity of ankle arthrodesis after total hip arthroplasty.
Thank you, Dr. Stanislav. And the other question is, what is the risk of prosthetic joint infection in some of these patients where you have done a stage procedure?
Thank you for this question. To be honest, in my practice, the rate of periprosthetic joint infection in this category of patient is about 5%. For me, it's a really good result. It's connected with adequate antibiotic prophylaxis and good curettage after removing external fixation devices, waiting until the complete wound healed after first stage. And but really, this two-stage technique at unreduced fracture dislocations of hip, in cases when dislocation more than 4 centimeters, give good functional outcomes for patients, and patients happy after this surgery.
Thank you, Stanislav. I think that's all the questions that we have for this session. Fantastic lecture, and I'm sure this lecture is going to benefit a lot of people all over the world. Thank you so much for joining in.
Thank you.